Professor Guy Ludbrook is Professor of Anaesthesia at the Royal Adelaide Hospital, Head of Acute Care Medicine at the University of Adelaide, and Director of an Early Phase Clinical Trials Unit, Park Clinical Research. His research background is in pharmacology, including pharmacokinetics and pharmacodynamics in the central nervous system, and more recently in early phase drug development in partnership with industry. He has an interest in medical device development through academic and commercial research, and in device regulation through the Therapeutic Goods Administration. After some time at the London Business School, he has developed an interest in innovation in health service delivery, especially related to the value proposition of both outcome and cost. He is active in research into improved evidence-based models of care pre-operatively and post-operatively. Please welcome Professor Ludbrook.
Thank you for that kind introduction. I want to talk today about a topic that we need to talk about more and haven't enough, and that's about post-operative care. Now, first, in terms of disclosures, I have a number of contracts with industry. If you go to that website, you'll see most of them, and they include some of the sponsors here today. I work in regulation of devices with the TGA, and I get involved in trying to improve healthcare in a number of fora which are outlined above. So to navigate tonight, I want to talk about challenges in healthcare. How do we go about addressing them? Is there actually a problem in our space, and what can we do about it? It's probably a little simpler than that suggests. So let's talk about the landscape. We know about that. Population changes, age and chronic disease, we know about that. Emerging poor outcomes, we have to think about health and economic outcomes. Just scaling up services is not going to do it because we will run out of money. And we have to look at alternatives, which is difficult, challenging, but essential. So this is the population profile before I was born, sort of a few years ago and well into the future. And these are the classic curves known as the middle age spread, which some of us know too closely, and the coffin-shaped curve of the population profile into the future. And for those of us of a certain age, and you'll notice the error bars in this line are quite wide, I would have been very lonely back in the early 20s. I'm amongst friends in the 2000s, and will be well and truly in the pack in 2045. This is a reality. And this is how it manifests. So we have conflicting pressures and we have a changing environment. We have to look at increased demand. We recognise our resources are constrained. We have a changing society and a changing technology. I don't expect you to read that paper, it's from 2007. It talks about some of those. It also talks about workforce challenges, but that landscape has changed substantially since then. Nevertheless, the problems still exist. So how do we go about addressing these problems? It's all about quality of care, but we have to define that very carefully, and I prefer to turn to the STEEP principles of quality of care, which are an international standard, and I think we should always turn to these. And they're about things that are safe and effective, and that's often what we think about. We often forget about things that are timely, efficient, equitable, and patient-centred, and we must do that. We also have to think about the value proposition, and increasingly it is quality over cost. And in that arena, better outcomes of higher cost are fine, and it often relates to expensive gadgets or drugs, and they're important. Same outcomes and lower cost are something we should aspire to, and that relates to the efficiencies in STEEP principles. And then the holy grail, if you like, is better outcomes at lower cost, and that can be achieved, but only if you think about it. We have to be creative and innovative to do that. We have to try new things and take a few risks. And we have to evaluate carefully on the value proposition at every step. We can't do this carelessly. And if you like, that's what health services research is. So a couple of examples where perhaps a bit more rigour might have helped. So this was from the BJA in 2016 about the high-risk surgical patient multidisciplinary teams. And we hear a lot about this. We hear about the patient journey and perioperative care teams and so on. What evidence is that it's helpful? There's not a lot actually. And this was an interesting paper. Look at cost. Well, the cost of a multidisciplinary team may be as much as 50 nurses or 20 consultants. How do you know it's doing better? That's a big spend. In terms of clinical outcomes, we're scratching a bit. An impact on pneumonia, delirium and length of stay, perhaps. In terms of the patient experience, well, that's really an unknown. So you have to question how far we should advance with such an approach without a decent evidence base around the STEEP principles or the value proposition. Now, I've deliberately masked this paper because it's close to home for some people, but this is a logical high-value service. It's logically better. And this has been studied using NH and MRC money at the highest standards. And this service, which is not cheap, clearly showed that length of stay was no better or worse, that costs were no better or perhaps worse, complications were no better or perhaps worse, and mortality was no better or perhaps worse. So why aren't we investing in that? I don't think there's anything fundamentally wrong with the service, but are they seeing the right patients? Are they giving the right sort of management, or is there something else? But we can't turn a blind eye to something that has a cost and with the highest rigour is showing no outcome. And we have to think about what are the high value elements of care. I did a lot with cool drugs and cool devices. That's a new analgesic we were testing today on volunteers on the left. On the right is a respiratory dialysis machine which can be used to take the CO2 off people with asthma and prevent intubation, which is associated with a less risk of mortality and length of stay, but it's not proven in terms of outcomes. So how was that approached in the regulatory world? We let it into tertiary centres where we could get good data to find out whether it was good or bad, and I have no idea where that is. Don't forget about people, because people are incredibly good. They're probably the most expensive drug you ever bought if you think about what we're paying per hour. So that's all fine, but is there actually a problem in our space? Well, there is. So this is the Reason study, which is a few years old now, and looked at all post-operative complications of people greater than 70. Now 70 is pretty paediatric actually these days, I'm afraid. 70 is the new sort of middle age. And if you want the definition of middle age, it's 2/3 of the way through your life. And for the record, the math says I'm 65.92% of the way through my life, I'm not middle-aged. My children find that as amusing as you probably do. But in this study, 5% of patients had died at day 30, 20% had suffered complications, and nearly 10% were admitted to the ICU. So this isn't terrific. Post-operative mortality is the 5th highest cause of death in Australia. No one knows that. If this was a disease that is the 5th highest cause of death in Australia, there would be, people shouting from the rooftops, this is something we must address, it must be a priority. Obesity is a priority, hypertension is a priority, heart disease is a priority. This isn't, and it should be. So if we look at what happened in that particular study of who ran into trouble, there were the very high-risk cases, those who are ASA4 and very old and terrible, we know about those. But let's look back a bit in terms of those patients who aren't quite as bad in terms of the outcomes, but have complications or comorbidities that we see all the time. ASA3, a bit elderly, some mild single system disease. That's the landscape that we live in now. So we thought we'd have a look at this. So we looked at the medium risk patients that we see every day at the RA, and we studied 750 odd patients serially that went to our recovery room. And actually they weren't that sick. Mean age under 60, most of them ASA 1, 2 or 3. nice grade of 2 or 3 is quite minor surgery actually, and relatively brief surgery, at least in the RH context. So this wasn't a nasty cohort. I was surprised at the figures. So what happened? They got into trouble a lot and they needed MET calls. So of those, 20% had adverse events in the recovery room, just under that in the ward, and 5% needed MET calls, for want of a better word, which is a close figure to that Reason study I quoted before. What was interesting is that if they had problems in recovery, it was a sign of trouble. So if they had hypotension in recovery, they were 3 times more likely to get a MET call later on. If they were desaturated, twofold. And if they were over-sedated, they had 10 times the risk of getting a MET call. That's a scary figure. Sedation is something we need to look at just a little bit more closely, and perhaps why they got sedated. More importantly, they get into trouble early, and this is a theme I want to talk about today. So if we look at the common things, low blood pressure, desaturation and MET calls, most of them happened early. You can't have a MET call in PACU, you probably can actually, but look, most of them occurred then or before the sun came up the following day, and most of them faded away thereafter. So I just want to think about that period between when you sign the patient out of recovery and when the sun comes up the following morning. So we tried to look at who these were. So the NSQIP is the American College of Surgeons risk score. You can go online and score your patients. I do that quite a lot and actually share it with the patients. It's nice, it tells you a lot about the complications. It's not perfect, probably the best validated risk score in the world over millions of patients. It's a bit American. So we looked at all the patients who got MET calls and all the patients that ended up getting at least ICU consults. And what we saw was there was a big group here that was ASA 3, the same for those that saw ICU staff, and that pretty much lined up with the NSQIP 1 to 4%, which is the red line on the horizontal axis. So we're talking about a similar thing. Now NSQIP also takes into account the surgery, but we kind of know what we're talking about. This is a group of patients that we see all the time. Now, risk prediction and triaging is a topic in itself and involves mathematics and would have you asleep in no time. So all I'll say is that pre-operative, the risk of early post-operative complications is a composite of patient and procedure. Immediately post-operative, that risk may be defined by events in recovery, or as I'll show you shortly, perhaps not. The other thing to think about is what risk do we worry about? So what defines risk? Patient factors, surgical factors, institution capacity, and other things that we can't identify. What's the risk we're worrying about? NSQIP talks about 30-day mortality. Am I fussed about mortality, 30-day mortality? Of course. Is it in my space? No. But it actually acts as a surrogate of other things. So what's my priority in terms of that value proposition in terms of outcome and cost? Is it in-hospital problems, morbidity or complications, 30-day mortality or length of stay? And in whose domain is the post-discharge issues in terms of representations or readmissions, quality of life or return to independence or return to work? We can't ignore that. That mightn't come out of our budget, but it comes out of someone's budget. And at least if you know about it, you can dance around who's paying for what. Never forget that part. So what can we do about it? Well, we can probably do what we've been doing for some time and kind of pretend it isn't there. But let's understand the cause and try and address that. Now, we don't have perfect data on this, but we have some, and some of it's a bit scary. So these are data from this year, from Dan Sessler, and those of you who are in Sydney may have heard him. It was a terrific talk. He summarised it perfectly. Does blood pressure matter in the operating theatre in terms of mortality? They looked at just 100,000 patients, and they looked at the association between time-weighted averages of blood pressures and 30-day mortality. And let's not get excited about the mathematics. It's not exciting, but this is what they came up with. So look at the left-hand graph because that's most illustrative. So we're looking at mean arterial pressure along the bottom line, and your risk goes up if your blood pressure is low, quite steeply actually. And it goes up a bit if your blood pressure is high. Let me suggest that the high is probably more related to comorbidities, but it's the one going the other way that's an issue. So that cut point we can debate, and people will argue the toss around is the cut point of risk, a mean arterial pressure of 60 or 65. I don't really mind, actually. I don't think we should go to town on that. But there's clear evidence that blood pressure influences mortality. But look at the bottom axis. It's about time as well. It's people spending time with hypotension. Now that's fine, but the story gets worse. So, because we need to manage blood pressure well. This is a reanalysis of the POISE-2 data, which was 10,000 patients looking at something else, aspirin and clonidine to prevent myocardial infarction. But they went back and looked at hypotension, a blood pressure less than 90. Now, most of us wouldn't turn a hair. I mean, how often would you worry about doing an RDR chart saying blood pressure less than 90 or greater than 90 is fine? We do it all the time. And we need to think about that. So this is kind of interesting. So hypotension, as defined by less than 90, was very common in theatre and very, very common the rest of that day. It was less common on the post-operative days 1 to 4, but it appeared a loss for the rest of the day. I'm not sure whether that was day or night or not, but don't just worry about the operating theatre, worry about what happens afterwards. And in fact, there's a very clear association between 10-minute changes in blood pressure and your risk of having a significant outcome, which is increased 30-day mortality. So the numbers don't look that impressive. So if your blood pressure drops in theatre, there's a 1.08 highly statistically significant increase in risk, and that's 1.03 if you're hypotensive the remaining day of surgery. When they graph that another way, it gets a little more interesting. So if you look at the duration of hypotension, that curve is steeper in terms of risk in the operating theatre, but it's certainly highly significant outside the operating theatre as well. So our tolerance for hypotension needs not just be about numbers, but also about time. This is another paper come out this year, and these are emerging data. We're going to hear a lot more about this, but the association between post-operative blood pressure and myocardial injury. 2,000 patients, lots of patients over 60 years, quite paediatric, retrospective analysis, that's okay. Troponin, very sensitive troponin measurements against mean arterial pressure. So if your troponin went up, what was the blood pressure just before that? Now, if you look deeply into the paper, you'll firstly find out that most of those troponin rises were early and they tailed away. A little bit like the data I was showing before about, the risk times are early. It's day one, it's not intraoperatively. Secondly, if you look at the associations, so if you look at the lowest blood pressure and the risk, and the red lines are the mean and the dotted ones are the error bars, and they're large, but both of them show us that there is an association between post-operative blood pressure and troponin rises. Now, people will argue that troponin doesn't mean anything, it's due to myocardial leak or something else. I beg to differ. So Devereux in the VISION study, a big study, looked at the relationship between troponin rises and 30-day mortality, and it's a nasty linear curve. And as troponins get more and more sensitive, we'll identify myocardial injury more often, and it's steeply associated with bad outcomes. So we can't pretend that the troponin rise is just because they're a bit septic or they've got a high creatinine or it's just some irritation. It's probably not. And almost all of this is silent ischemia. Don't expect the patient to have chest pain, they don't. So we know a bit more about blood pressure than we did 12 months ago. We know a little bit more about fluid management as well, and the release of these data about the RELIEF study is kind of interesting. So we've known that patients run dry will protect their bowel. If they're wet, we risk their lungs and their bowel and their wound healing. There are rat data from many years ago to show that. But the story is a bit richer than that. So this is a lot of patients, a well-done study to say, what happens if you give some fluid to some patients and less to others? Well, firstly, what's the difference? The difference is about 1 litre to 1.5 litres and a weight of about 1 kilogram. So these aren't widely separated groups that are run dry as a prune or wet. It's a very subtle difference. And then it gets a bit scarier. So fine, there was no difference in mortality at 12 months. That's fine. But if you were run a litre dryer, your risk of getting a surgical site infection, these are often deep organ infections, went up by 20%, and your risk of acute kidney injury went up by nearly double. Now, intriguingly, that wasn't associated with increased risk of death, and I do wonder about that. Cork showed in December 2015 in a big series of 40,000 patients a very strong association between creatinine rise and mortality. So, as an independent predictor, so I'm not actually sure that we can be comforted by the fact that there isn't a translation into mortality. Those numbers are pretty low. Death is a sort of not the greatest indicator. We don't have a lot of data on other aspects which may be relevant to that value proposition in terms of recovery. But that's pretty scary. A litre here and there can make a dramatic difference to your patient. So what can we do about it? Well, we can think about providing a high-value care delivery model. So what should that be? We're thinking that blood pressure is important. We're thinking that fluid's important. And there are probably 10 other things we don't even know are important yet. We can use intensive cares, and they've evolved actually out of this space, and they provide very advanced care, and they're expensive. And I said to the surgeons the other day, you know, a ward costs about the same as a Toyota, and an ICU costs about the same as the Bentleys that you're probably driving. So you can imagine the response I got from that, but it's about a 7-fold difference. And that's a big price difference, actually. Can you think of anything you can buy in the street that there's something of this price, something 7 times greater and nothing in the middle? It doesn't sound like it's particularly priced to fit a need, does it? And I don't want to offend people about talking about price, but price relates to intensity or degree of care, and it's not a bad surrogate of that. And it's interesting to look at the variability of ICU bed numbers in Europe, and this was a quite fascinating paper looking at ICUs, and it's interesting that some very rich countries like Germany have a whole lot of ICUs, but there's some very rich countries like Scandinavia that have very few either. So we can't turn a lot to that. It's just kind of an interesting discussion point because there are other care models that don't involve ICU, but this is quite a dramatic difference. We can use outreach teams, and David Story, who we work with, had a good look at this, and they looked at ICU level nurses and registrars doing daily post-operative rounds on patients. And it was a great idea. Their initial study was quite promising, but their final paper wasn't, and there was no effect on length of stay or MET calls, which are the best sort of surrogates, if we can, of outcome. And David is the first one to say that he was disappointed in that, but is convinced that that's not the answer. So why is it not the answer? Timing of assessment once a day. If we look at that relationship and the criticality of fluid and blood pressure and time, turning up once a day doesn't really sound like it's going to cut it. And what can you actually do on a ward? So, medical emergency response teams, MET teams, are a terrific idea. And Ken Hillman, who really was the father of these, sits on our advisory committee on the work that we do. And we can argue a lot about this, but MET teams do increase emergency team calling, but don't really affect the incidence of cardiac arrest, unplanned ICU admissions or unexpected death. Now, the number of papers on this is extraordinary, and we have some of the best expertise on this actually in this state. And I won't get into an argument about it, but we do know that often MET teams are not called when they should. But firstly, you have to be pretty sick to get a MET call. Look at some of those parameters and look at some of the data that we talked about earlier, and you wonder about the gap. You may have been this way for quite some time if you're on 4-hourly OBS, and the criticality of time and blood pressure we've spoken about. We know that the affect or arm of actually calling a MET team is way underutilised. And what ongoing care can be provided? You can have the cavalry come in and do some stuff, but after that it drops often away to the same level we had before. There's many ways of dealing with that and the ways of getting around that, but it always will have some limitations. So like most things, the answer is actually in history. So let's go back a bit. So this paper was published in 1995, looking back at recovery rooms. Now, has anyone here worked in a hospital that didn't have a recovery room? That's a loaded question because I know at least one person did, and you don't have to be that old to do that, and I'll show you why. So, why do we have recovery rooms? It's provided somewhere a patient can be kept until sufficiently recovered to be removed to the ward. Logical. They were in extensive use in America in the late 1800s. Terrific. They were largely forgotten, certainly in the UK. So when they came back in the 1940s, they were very unknown. So there were hospitals being built in the 1930s and 40s that didn't have recovery rooms. It's not that long ago. This is a lovely paper by Gardner looking at the 4 years experience of recovery rooms from 1964. That's not very long ago at all. So it wasn't that long ago that we were sending our patients, we were waking them up and sending them to the ward. Maybe they went okay, maybe they didn't. To get an operation in the early part of the 1900s, you had to be pretty healthy, and it wasn't that exciting an operation probably compared to what you see today. But the ideas about recoveries back then were exactly the same as ours. It's about shared care. It's about physicians and nurses and anaesthetists working together to input into the patient. It's about being in a place where there's access to the right sorts of staff. And it's about some continuity of care. And interestingly, they were talking about priority setting even that long ago. But the perioperative case mix has changed substantially since those days, and recovery rooms have not evolved to meet the needs. And if you just look at some of the data that we've talked about already this evening, it becomes clear why. And we still haven't got it right. We're judged poorly in this country if our recovery room length of stay exceeds 2 hours. That's the quality indicator. It seems ridiculous, actually, but that's what it is. We should celebrate being able to have our patients stay in recovery longer if they need it. And actually, we disinvest in care too early. So the white graph is the spend per hour in relative terms in the operating theatre, and that's way off the scale. In our recovery rooms at that first inflection point, and then down on the wards. So down on the wards, it's about $750 a day, something like that. And then against that, we look at the rate of decline in the same relative scale of the cardiorespiratory complications that we measured. And there's a gap. We dramatically drop our investment, and when I use money, I don't use it carelessly because investment relates to some degree the intensity and the skill level provided. And there's a significant gap there between, not coincidentally, when we leave the operating theatre and roughly when the sun comes up the next day. So we started thinking about the start of last year around what we should do about this. And I'll show you why, and I'd like to acknowledge this wonderful logo which I had to pay my son to produce, but anyway. We thought about something with recovery room capacity that has a nursing ratio that we don't know yet. Attended by anaesthetists, nurses and surgeons, but doing what they usually do. I'm not here to dictate how people practice. If I had to argue that a blood pressure of 60 or 65 was the correct level, would be here all day. The MET team in the MERIT trial said, do what you usually do, but have a team arrive with expertise and do what you usually do in that hospital. We felt regular rounds were necessary, and we've been guided, in fact, to do that more frequently, and we're seeing patients hourly for the first 2 or 3 hours, and I think that was a good decision. We see them thereafter as needs be, and we have to change that. And the following morning, we make a good assessment and decide where do they need to go. That was the thesis that we came up with. Who did we want to study? Well, just those patients that I spoke about, the ASA3 sort of patients, these medium risk patients that no one would ever think of putting in an ICU. So it's roughly ASA3, Nesquik 1 to 4%. We pluck that out of the air. And we've got permission to actually do this with opt-out consent, which is kind of nice. So what are the principles of this? Firstly, you've got to identify the patients, and we use a certain degree of rigour, but nothing's that rigorous. I've said risk prediction is an inexact science, and that's understating it. We do continuity of care. We use appropriately skilled personnel. We use existing infrastructure. And we're putting in care at the time of the greatest risk as best we can define that, and I've shown data around that. And then at day one, we have a good look at where we are and decide what are we going to do. We could hand them off to the surgeons, we might get the physicians, the geriatricians, orthogeriatricians involved, and we may need to use HDU or ICU care. So is there any evidence that this is anything more than a flight of fancy? These are the only 3 papers in the entire literature which tell us something, which is a bit of a worry. This is the first one. So this was a couple of years ago, Division of Anaesthesiology, recovery type care, lower nursing ratios. It had a bit of kind of HDU to it, to be quite frank. These were sicker patients than just medium risk, and it was very well structured. It was the Swiss, of course. So what did they find? They found that in-hospital mortality halved and unplanned ICU admissions did the same. It's a model that's not the same as what I'm talking about because it's a bit more complex. Nevertheless, it was the best piece of data around until 18 months ago. This is the paper that caught my eye. I reviewed it and wrote an editorial on it. Just be mindful that the abstract that they've published is in error and they've reversed their results, so read the full paper. But they look back at patients and why. This was simple GI surgery such as reversal of Hartmann's. And why did they do this? Because of something we will face, undoubtedly. They didn't have enough HDU beds anymore for these patients. They used to send them all to HDU. They ran out and they were cancelling cases on the day of surgery. So they made a policy decision that they would just crack on, and if there was an HDU bed, they'd go to it, and if there wasn't, they'd go to the ward. Not an unreasonable thing. We understand the financial pressures of the NHS. These weren't very sick patients. I've already said 70s young. Mostly they were ASA 1 and 2. And what happened to them? So if you went straight to the ward, you stayed in hospital 3 days longer. You bounced to ICU a lot more. And with a very, very crude financial analysis, it cost a bit more. I wouldn't argue the toss too much about the last one, but these patients ran into trouble a lot. And actually, if you look at the data, the slightly sicker ones went to HDU. The ones on the ward were slightly healthier, which doesn't surprise you. There was a bias to send them to HDU. It wasn't a prospective study. I also reviewed this paper, and I do apologise that they didn't, it's only quasi-experimental. Even then, experimental is not spelt right, but I don't edit for the journal in terms of the last things, just the data. But this is actually really, really quite insightful. They wanted to know whether improved structured care in the recovery room made a difference. They wanted to know whether a checklist meant that they saw patients in trouble more, a bit like a kind of Met call, I suppose, whether or not it gave better documentation for ward handover, whether the outcomes might have improved, and whether it affected costs. Now, the results are presented in an unfortunately quite a complicated way, and I'll only point to 2 things. So if it's tall, it's not good, and if it's small, it's better. So let's look at those orange arrows and the green. So in terms of clinical deterioration on the ward and cardiovascular problems on the ward, those bits of green shrank. So this was a healthy group of patients that weren't expected to do badly, and they got a signal that suggested that patients who were more exactly treated in the recovery room, but not for longer, actually had better outcomes on the ward. And it's quasi-experimental, it's a different cohort, but it kind of speaks to the sort of rigour that we have to think about. So I think it's a bit like a drug. This is CMX-020, which we gave to 4 people today. They're all fit and well now still, and this is an analgesic that could be a game changer. This is probably as potent as fentanyl. It doesn't cause respiratory depression, nor sedation, nor nausea. It might have something else, of course, But let's say it does produce analgesia, and we do know that it does, and it's available IV. So we have to think about these, because these would dramatically change the landscape if they were any good. But how would I approach that drug? Well, I would want to know, what's the optimal dose of that drug? How long do you need to stay in my recovery room? What's the optimal means of delivery? Who do we want looking after you? Who's going to benefit from this drug? And how can I make it better or evolve it? Because drugs evolve. For that, you need an evidence base, formal trials, and outcome and cost endpoints. You can't do this carelessly. I pointed to 2 models of care earlier at the start of this talk, which are expensive and seem to have no value. And it's very important, because this is some rough cost analysis of what we have done and what we're trying to do, and the pricing points vary dramatically. And we can't be careless about this. If it doesn't produce benefit in terms of funding, then we need to understand it must produce a good benefit in terms of outcome. If you think about outcome cost proposition, I don't mind if it costs a bit more if the outcomes are great, but if the outcomes are poor and it's very expensive, we need to pack up and go home. So this is what we're doing. This is a before and after feasibility study. A feasibility says, can we do it? And maybe we'll find some data about benefit as well. So for 3 weeks, we take 3 to 4 moderate risk patients, I've said what those are, and we just follow them on the ward and out to 90 days. Then we work out how to set up an advanced recovery room. Now, I acknowledge some of the people in the room today who've done a spectacular job in helping with this, because this is something you learn how to do. But what it is, we put our patients there and keep them till the sun goes up. We find out what their risk is ahead of time as much as possible in an emergency type setting. Some of these are emergency cases. And we follow them with what we usually do in the recovery room. There's a degree of rigour, and I mentioned about those regular visits. Otherwise, we give the care that we judge to be the best sort of care that we can provide. It's not traumatic. We don't ventilate patients. We're very careful about the use of inotropes. It's what you would do in a recovery. So we're in week 3 of week 4 bedding down, and we're about to embark on the 5 weeks of running it absolutely flat out. What's been the experience so far? And there are people in this room who'd love to share it, I think, because it's really been a group effort. In rough terms, half the patients that we have treated in the last 3.5 weeks have had extremely serious complications. Sadly, often they've occurred late. So we'd go home at 10 and say, this is terrific, and be unpleasantly surprised. That worries me, actually, because I thought that we would see signs of trouble, deal with them, and move on. So those are very rough figures, and you can't say anything by those. The numbers are small. But this is a substantially higher problem rate and a substantially higher unmet need than I had anticipated. Nevertheless, we're coping and patients are getting good care. Then the 5 weeks will be interesting and busy. And what are we looking at? We're looking at outcomes that matter to different people. So a hospital might be worried about quality of recovery, MET call rates, ICU transfers, reoperations, death, the length of stay. But the community might be more interested, or community healthcare givers, about representations, death, days alive and out of hospital, which is now a very common metric, and quality of life at 90 days, because it seems very plausible that if we treat a patient well for 6, 12, 8, 18 hours post-operatively, we may see a signal at 90 days, and there's quite good reason to believe that may be the case. If you don't look, you won't know. This is the people that we have involved, and it's a pretty cool group of people, but I've highlighted in yellow where they come from. It must be multidisciplinary. It's got emergency medicine, health economics, physiotherapy, evidence-based medicine, and biostatisticians, because you need this sort of a team to actually do it well. So this is across 4 states. It involves a whole lot of people who are very, very well credentialed, and that's what you need to actually find out whether this is right or not, and that's what we're trying to do, because if it's not useful, we don't want to do it. So these are the hospitals involved. Just at the moment, this early phase, Cairns ran into trouble because I think, Louise, is that right, that unless they had a dimmer switch, their patients might be disturbed at night, so the board is just approving a dimmer switch before they can start. Okay, that's okay. So what's broken and how can we fix it? Well, I think we have to be optimistic and resolute, and we need to turn to the evidence. And I think one of the most published and recognised people in this space is Paul Kevin Joyce, who most of you probably don't know, who has a BSc in applied biology. And he's developed a program around some very important principles of conflict resolution, cooperation, socialisation and learning skills. And they're embedded in this program, and I think you'd probably have to agree are probably what's going to be needed if we're going to progress. And you probably don't know Paul, but you've probably heard of him, because he wrote the song Bob the Builder, Can We Fix It? Which may or may not play. I'm going to stop there on a moment of brevity, but it's not actually an area we can take lightly. We've got a bit of an unmet need. We need to think about how we fix it, and we need to be resolute, and we need to believe it. Yes, we can fix it. Thank you.
Thanks very much, Guy. Do we have any questions? Steve?
With your patient selection for your routes that you're currently running at the Royal, are you applying SQIP scores to each of them? Or are you just looking at them and saying, well, this person is about the right level of sickness and we're just looking at the
No, we apply NSQIP scores, so 1 to 4%. Now, I said risk score is an inexact science, and it's a very inexact science, and you can not quite make the numbers mean what you want, but there's a huge amount of uncertainty, and you risk score on different risk scores, you get different results, and markedly different results. The benefit of an SQIP score is, firstly, it's free. Secondly, you can get it on your phone and score someone. And thirdly, you can print that out very readily. But it has a risk adjustment thing at the end. And some of the scores, like the UK ones, don't. And they're actually, I think, a bit too restrictive. Because it says, do you think this patient is a bit more at risk than this says, or a lot more? And you press that button and it will change the numbers. And I think that's important, because this uncertainty, and the eyeball test is pretty terrific, let's face it. We use a strict score, but there is that sort of fudge factor. The score is not perfect, okay? Hip replacements score very lowly. So you can't get, I had a NOF the other day who was 90, past history of CCF, I couldn't get her above 0.4% mortality. I mean, that's ridiculous. But I pressed I think she's at extra risk, and she spun into the 1 to 4% pretty quickly. So, you know, there's some things that don't work, but look, none of them are perfect, but it's good enough, I think. Will we change it? Almost certainly. We won't end up with that. It's not quite right. I'm not sure where we'll end up, but it's a very interesting learning experience. You can sort of almost look at a patient now and calculate their NSQIP score if you've done it enough times.
Rob?
Guy, 2 questions. Do you get the sense that the surgeons are supporting? First question. And the second question is, what you describe as a relatively simple concept of identifying high-risk patients and providing a relatively short period of more intensive monitoring and early treatment. So I'm just trying to understand why there's maybe been a lack of interest in that concept up till now. I'm trying to understand that in terms of trying to understand what the obstacles are for addressing that.
Excuse me, Guy, do you want to repeat the question?
Sure. So Rod's interested in what do the surgeons think of it, and I guess why is this not sort of come up on the radar earlier? The surgeons are very enthusiastic, especially sort of after dark. But I think it's a bit unfair. So we had a 60-year-old lap colectomy the other day. I mean, case reports are, you should never talk about them. Terrific, fine. I go home. She ends up on vasopressors and in ICU the following day. She had this sort of, vasoplegia that we don't really understand. She did that late, which worried me. She did at 2 in the morning. But the surgeons were very helpful. So they're very happy to come in. Shall I come in and round with you at 6 o'clock? You're not for around at actually 2 o'clock, but that's okay. So they're very supportive because I think they understand that there is an unmet need. Now, who's going to do it and who's going to do the heavy lifting? I think that needs working out a bit. But I think there's increasing understanding that things aren't quite right, and some of the specific data we've showed today points at perhaps why that is. So I think there's increasing recognition. I think the relief trial will be debated for a while, but it's staggered a few people. Why haven't we done it? I guess we probably to a degree it's come on gradually, I think. It's something that's crept up. If you look at the complexity and the problems, they've kind of crept up on us over decades actually. So it's not a sudden change. Secondly, we often use pretty crude endpoints to measure, like mortality within 24 hours of anaesthesia. It's never going to score in this. And lastly, I guess we've not been certain what to do about it. So we've tried some things, outreach teams, and it's good, MET teams, and they still have a place. They're important despite the lack of perfect data. They have a place. But I guess we've struggled to know what to do and when to do it and what would be a decent value thing. So we could beef up ward care to an extraordinary level. So PJ Devereux will tell you every patient should have semi-automated remote monitoring on so you can pick up desaturation, blood pressure and so on. What I've said to him is, when it's detected, who's going to fix it? Because it's not easy. You've got hypotension, you've got CCF, who's actually going to do it and where are you going to do it? So detection's only half of it. I think we've struggled to know kind of when to put the effort in. Now, I've punted and said it's that first whatever till the sun comes up. Is that right? I'm not sure. Certainly my original theory was we'll get the patients in, we'll buff them, we'll all go home and we're all tucked in bed by 9 or 10 at night. Sadly, that's proven not the case. So that's troubled me a little bit because the problem is bigger than I thought and it's probably longer than I thought. So we're just hypothesis generating here, right? I think we're trying to find out what is the problem and we haven't really measured it enough to kind of know. So when we get a better handle on that, we'll have a better handle on what the model is. Now, I don't know if what we're doing is the right answer. We've already changed our view on subtly and not so subtly already, and we've only been going for a few weeks. But the data have staggered me, to be quite frank. So all I know is that I think the status quo is not an option. I think we can do better for our patients, but how we get the best model, I think we're heading in the right direction. I think that early stuff makes a lot of sense. I think that continuity of care, and anaesthetists too would all prefer to be home when the sun's down, but we kind of know how these patients behave. This is what we do a lot. And it's usually single system as well. If it's getting complicated, our ICU colleagues are much better placed to do that, and these are going to be longer term problems. But if you can fix some hypotension, fix some hypoxia, fix some fluid issues carefully, and the patient thrives, that's great. If they haven't, then there are other options as well. So, look, I think let's be creative and let's not pretend it doesn't exist. So we've pretended because it snuck up on us and we probably haven't wanted or known what to do. Let's bring it out in the open and have a crack at it. But let's measure it properly and make sure that what we're doing is beneficial and not kid ourselves.
I just want to make a comment. I think the implications of the results that I think stroke hope are going to find is that there's a segment of patients that we anaesthetise, particularly in private, that aren't sick enough that we have to or look like or having surgery. We think, no, we can't really do that here because it relates to you. But they are in fact the patients that then deteriorate a bit, often in a smaller hospital, don't get this review, and even if they do, they're not in a place where you can act on it properly, and then something bad happens.
So the question in comedy is really about advanced planning. Can we anticipate not just where we'll put them within hospitals, but across institutions? And I think that's a very important point to make. I think, we also do work in the pre-operative risk identification place, and we need to be able to do that better, again in a cost-effective manner, to be able to start triaging early on. It's never going to be perfect, but you're absolutely right. So I guess I was most drawn to this when I was in Western Australia with Western Australia Health, and they have, it was Royal Perth in those days, not Fiona Stanley, and they have this sort of private orthopaedic clinic, and they were ending up some pretty wobbly patients in the sort of private orthopaedic sort of standalone centre, and they needed a better triage. You're absolutely right. It doesn't start with, the patient hitting recovery. It actually starts way back. The problem is we're always going to have an element of doubt. The best risk prediction model is going to be wrong about a third of the time. So there's wastage in that. But at least we can get closer. That's okay.
So Guy, this all sounds like, a really great concept for a larger hospital. Where do you see the smaller hospitals then that just don't have those sort of funding models? And particularly then we're looking at the private practice, the private centres where, you just don't have people who can be there. And should we be encouraging the facilitation of, larger centres as opposed to, Sportsmed, Northeastern, those like little places just popping up and just coalesce into, another large unit?
So the question, I guess, really is, do we need to think more carefully about what patients should be done where and not do some patients somewhere? Well, things sometimes change with foresight and sometimes change with hindsight. And I mean, you mentioned Sportsmen, and I don't want to pick on them particularly, but they have been drawn to a new model of doing higher risk cases in bigger places, and that has worked very well. Are they perfectly triaged, and who does that? And we have to, think very carefully about that. Who's best placed to judge risk? And it's probably relevant to that masked paper I referred to earlier in the talk. But I think we have to have those conversations. And if that's uncomfortable for standalone centres, I think that's a degree of discomfort that we have to sort of bring out and talk about. Because who runs into trouble? Well, it's our patients. I think we have to have a bit of self-protection too. I mean, how many times you've had to sign a patient out with a variation on an RDR chart that really makes you uncomfortable? And I have to do that quite a lot. And we usually get away with it. We thought we did, but I'm not sure that we are. So I think we're right. I think this triaging will be about within hospital care, but it'll also be across institutions as well. And we have to think carefully about that. And if that drives some institutions to coalesce so they can provide better facilities, I think that will be better for us all.
One question. You touched on sedation in recovery being a risk factor. Could you elaborate on that?
So we see that if you're over-sedated in recovery, you've got 10 times the chance of getting a MET call. I actually don't know. We know sedation, respiratory repression is a big issue. It's not just why they get MET calls. I guess you're probably wobbly in some weird sense, and so you've ended up being very sleepy because your brain is old or sick, or you're extremely sensitive to the drugs we give you. So I'm not really sure, but it doesn't just relate to sort of getting sedated and stopping breathing, it's other things. So I think it's sort of indicator of sort of fragility, which is also an interesting word, but I don't get into that, that's another talk altogether.
In that case, join me in thanking Professor Ludbrook. Brings the evening to a close, so please visit our sponsors and enjoy each other's company. Thanks for coming out.